Hi, everyone. Thank you for joining us for the Kirby Institute seminar series, the first one of the year. My name is Curtis Chan. I'm a research associate at the HIV Epidemiology and Prevention Program. I'd like to begin by acknowledging the traditional custodians of the lands at which we gather today and pay my respects to elders past and present. Today, we're meeting on the lands of the Bidjigal people of the Eora Nation, and I extend that respect to Aboriginal and Torres Strait Islander peoples joining us today in the audience and online. So some housekeeping to start. The format of the seminar will start off with a presentation by our speaker, followed by a Q&A session afterwards. If you're joining us online, you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. And for our audience in the room today, there is a microphone over here to the side of the room where you can ask your questions at the start of the Q&A session. So today, our speaker is Karinna Saxby, a research fellow at the Melbourne Institute, the University of Melbourne. Karinna's research aims to determine how place-based factors influence health and healthcare use amongst historically disadvantaged and marginalized populations, including sexual and gender diverse populations, Indigenous peoples, and people with disabilities. So I met Karinna because she approached us to run an analysis using the marriage equality plebiscite a couple of years ago and applied some of our data, and it was really interesting. I'm sure she'll talk about that today. And I'm really excited to introduce her today. So please welcome Karinna.
So thanks for the introduction, Curtis. Today I'm going to talk about my research, which is looking at structural stigma and LGBTIQ disparities in health and healthcare, specifically in the Australian context. Just before I get started, I'd also like to acknowledge the traditional owners of the lands in which this work was conducted, which is primarily the lands of the Wurundjeri and the Bunurong peoples. So this is the outline of the talk I've sort of got planned today. I'm going to start off with a bit of a 2-page preview of the research in our main contributions, so you can see what's coming. Then I'll provide a bit more details around background of what actually is structural stigma, some of the definitions and the mechanisms through which we think it could impact health and healthcare. And then I'm going to talk about some of my previous research in this space, including the research I did with Ben and Curtis here at Kirby. But then the rest of the time, I'm mainly going to focus on my working paper, which is mainly looking at disparities in long-term health conditions among sexual minorities. And that's actually what I would like the most feedback from you today. So I'm going to spend more time on that. And then summarize just implications from all the available evidence and talk about some of the plans for future work in this space as well. And the background and motivation for this work is really that it's very well known that members of the LGBTIQ community experience poorer health outcomes relative to the heterosexual and cis counterparts. And this is in terms of not only high prevalence of acute and chronic conditions, also greater risk of HIV among gay and bisexual men, but also very high prevalence of mental health conditions among the community. So we know on average, LGBTIQ peoples are more likely to have alcohol and substance use disorders, more likely to engage in self-harm behavior, and of course, at increased risk of suicide. And really, it's thought that one of the key contributors to these health inequalities are experiencing the stresses associated with structural stigma. So this refers to these sort of societal or macro level conditions that specifically disadvantage or constrain sexual or gender diverse populations based on their identity. So generally, this is conceptualized as things like laws against same-sex marriage, aggregated community attitudes, and things like that. And really, it's thought that this stigma could contribute to health inequalities by, first of all, excluding these groups from specific opportunities relative to others. So if we think about things like discrimination in the labour market and earnings potential, those sort of things are really important for health producing and human capital formation. Then if we think more directly, could be things like direct exposure to physical and psychological harm. And there's a lot of evidence around that. And then finally, potentially by inducing risky health behaviours such as smoking or alcohol use to sort of cope with exposure to those stresses. So I will say there's been numerous studies really outlining the negative mental health effects of stigma, in particular in the US context, but limited information on how this stigma could be affecting healthcare use and also longer term health conditions in this population, and also very scarce research in this space in the Australian context as well. So really with the aim to address that research gap, the aim of this research is try and understand whether structural stigma is associated with LGBTIQ disparities in healthcare use and long-term health conditions. And to do this, we used the data from the 2017 Marriage Law Postal Survey. We used the regional percentage of no votes, so votes against legalising same-sex marriage as a measure of stigma. We then map that to different data sources to look at various different outcomes. So we use census-linked admin data and the HIV behavioural servants data from Kirby here, the Gay Community Periodic Surveys. And then we look at these outcomes and how they change across different levels of stigma. So as a quick preview of the results, we find that as structural stigma increases or as opposition to marriage equality increases, we see that LGBTIQ individuals, they use more mental health scripts, but less preventative healthcare. And that includes fewer GP services, HIV-related care, HIV and STI testing. We also see that they're more likely to report long-term health conditions, in particular, high prevalence of mental health conditions and asthma. And really altogether, this contributes to this growing evidence that structural stigma is really important in shaping health outcomes in this population. And when you combine all of this research, it suggests that despite being in poorer health, on average, LGBTQIA Australians are using less preventative and primary healthcare. Okay, so now turning a bit more into the background about what is structural stigma. So there is no universal definition for what this is and no universal way to measure this, and lots of different definitions in the literature. But these are my sort of two preferred ones that I've stumbled upon, and they're actually drawn from the structural racism literature, but I think that they do apply in this instance. So I really like this one. It's by Bailey and co-authors, and this was published in The Lancet in 2017. And they define structural discrimination as the totality of ways in which societies foster discrimination through mutually reinforcing systems relating to housing, education, employment, and so on. And then this other paper by Alias and Parodies, they really conceptualize it as actions, policies, and practices that result in inequalities. So I really like these two definitions because I think it places more of the emphasis on societal and macro level conditions rather than placing more of the onus on the individual, for example, that other theories do, like the minority stress theory. So I think that these are really useful ways to conceptualize it. But also important to know that it's very difficult to then in turn come up with sort of empirical measures of structural discrimination, and specifically when you're trying to think about measures that are specifically constraining or disadvantaging specific populations within our society. So, for example, some people have tried to aggregate up community level attitudes, but this can be problematic because sometimes it's biased by sample that you're using to get these attitudes from, and also social desirability bias. People don't really truthfully answer the question. And then other approaches have tried to look at sort of aggregating up interpersonal instances of discrimination up to a regional level using police report data or something like that. But we know that this is also problematic because many of the instances of discrimination go unreported as well. So generally what I would say is that most of the literature in this space conceptualizes it through laws or policy or sort of temporal changes that have directly affected community sentiment at the time. So some examples of this overseas, specific to LGBTIQ community, include conversion therapy bans and variation across states, particularly in the US, similar approach for same-sex marriage in the US, and then more recent work looking at the Polish LGBT-free zones. So these are the kinds of, I guess, policies that they investigate to look at this. And then if you want to think about some specific examples in Australia, unfortunately, we have a few. So some examples you will definitely know about, but some potentially not. So in 2010, we only then changed the PBS safety net so that same-sex couples could count. And that means your total out-of-pocket expenditure towards healthcare could be combined at a family level. Before 2010, you were ineligible. So that's a real example of how you can be excluded from benefits, in particular healthcare benefits. Then, of course, we've had the Sex Discrimination Act changed in 2013 to explicitly prohibit discrimination based on sex and gender identity. Marriage equality 2017, and these are all sort of federal level policies, but we can also think about the variation across states and territories. So same-sex couples were differentially allowed to adopt depending on what state and territory you're on and different years. We still to this day have variation in access to gender affirming care, and things like conversion therapy is variable across different states and territories. So this is the kind of things people look at when they try and conceptualize structural stigma in this space. And then focusing a bit more now on how we think structural stigma could affect health and healthcare, there's quite a lot of different pathways, and I'm just listing a few here. But one of the sort of direct ways that's very easy to conceptualize is direct physical or psychological harm. And it's also been shown in previous research that areas that have high levels of stigma at the macro level are associated with individuals in those areas being more likely to express, for example, prejudiced views. And it's also been associated with higher rates of interpersonal discrimination. So there's that direct pathway. There's also the more factors pertaining to sort of health producing behaviours and social determinants of health. So as I mentioned before, access to housing, employment benefits, earnings and things like that. So you could be experiencing discrimination but not actually aware of it yourself, but you're excluded from participation in these things, as well as directly through being excluded from other things like health producing behaviours. So one specific example you could think of is recent debate about trans and gender diversity inclusion in sport. So very explicit examples here. There's also in turn, the sort of psychopathological responses from chronic exposure to these stresses, and then the potential to consume what they call BADs in economics literature, which is like smoking and drinking, to cope with exposure to those stresses. So lots of different mechanisms and pathways through which you can think to affect health. But it's possible, of course, that some outcomes might be more impacted than others. Exposure to chronic stress and coping with those stresses in particular, you might expect to really affect mental health. And that's what we see in the literature. The number one thing people look at and find is that exposure to stigma leads to poorer mental health outcomes. But we could also think about some other health outcomes that could be impacted, such as lung and cardiovascular conditions, asthma and CVD. And these have been all really strongly related to experiences of stress and things like that. And if we talk a bit more specifically about the literature looking at interpersonal discrimination, we've seen that all of these are all examples actually from the Australian setting, that people who have experienced interpersonal discrimination are more likely to smoke, have alcohol and substance use disorders, mental health conditions, asthma and CVD. So all really consistent with the sort of mechanisms we're expecting. And then to in turn think about how this might affect healthcare access and use. I think if we're in a dream world, you would think, okay, you're in poorer health, so you're going to use more healthcare. However, we know that people who are living in potentially stigmatizing environments are more frequently exposed to discrimination, maybe in and outside of the healthcare setting. So that could deter you from willing to engage with healthcare. There's also the possibility that you do access healthcare, but then don't disclose your sexual or gender identity to the healthcare provider, so you're not getting the care that you need. And in particular, there's been a whole bunch of research looking at that pertaining to HIV stigma at the individual level as well. So I've also just drawn this little arrow here, but basically you can see how these are really mutually reinforcing systems. And that's why I like the Bailey definition, because if you are not accessing preventative care, you're already in poorer health. You could see how that could lead to deterioration of your current health status and potentially eventually lead to chronic health conditions. And from an economic lens, use of more costly acute care down the line. So it's really important to consider all these things, not just from a societal and health equity perspective, but also from an economic perspective. So in terms of the previous research, there's been a lot done, especially in the US, looking at how structural stigma affects LGBTIQ populations. And most of these studies are very highly consistent. Higher stigma is associated with higher rates of psychological distress, alcohol and substance use disorders, and of course suicide. And that was actually coming out of a recent paper which looked at the anti-LGBTIQ laws in Poland specifically. And then again on healthcare access, not too much done on this population, but these two studies are from the US again, and they showed that stigma is associated with reduced healthcare access. However, important to note that the way people access healthcare through their employer-based insurance means that marriage equality over in the US is very different to what it looks like here in terms of accessing healthcare. Then there's been a lot more broader research, as I mentioned earlier, looking at structural racism, structural discrimination among other racial minority groups. And again, very consistent, we find that these measures are associated with high consumption of BADs, poorer mental and physical health, CVD, asthma, and actually mortality. One paper found higher risk of premature death. And then turning to the Australian evidence, we really don't have too much looking at structural stigma to date, largely because of these difficulties in getting these community level measures, and also difficulties in accessing data on sexual and gender diverse populations overall. So one study that was done in 2018 by Perales and Todd, they used the HILDA survey, and I don't know how many people know HILDA in this room, but it's like Australia's representative population-based survey, and it's actually run by the Melbourne Institute, so I should probably spruik it a bit more, but that was only a sample of about 550 LGB Australians. So it's quite a small sample, but nevertheless, they found very strong effects, and they found that areas that had a higher share of no votes, LGB Australians would report worse life satisfaction and poorer mental health and overall health relative to people who identified as heterosexual in the same region. And then just to talk about broader populations, I'm only mentioning this because this is another working paper I have together with some Indigenous colleagues. And we've already found that Indigenous peoples who are living in areas with greater opposition to the voice referendum experience poorer mental and physical health, less likely to engage with healthcare, and have more risky behaviours such as smoking. So all of this is very consistent, but I will say that there is limited work done on this space in Australia, and up until recently, very little done on healthcare use and then these long-term health conditions for LGBTIQ Australians. So given all that and that context, the aim of our research is to try and understand how opposition to marriage equality is associated with disparities in health and healthcare use among LGBTIQ Australians. As I mentioned before, I think different contexts are likely to be really important. It's important to have this evidence for Australia. We're considered to be relatively progressive relative to other OECD countries, particularly the US. So it's likely we're going to see different results. And then, of course, the other important aspect is this universal healthcare, as I mentioned before, very different to the US setting, where it's not only to do with marriage giving you access based on your partner's employer-based insurance program, but also things like the costs of accessing healthcare in the US are completely different to here. And then just to talk about why I think the referendums and the results from the referendums are particularly useful for us to look at these societal level factors. These votes were cast anonymously. They almost represent the full voting population. They were directly used to inform policy. And so I really think that these are less likely to be sort of prone to these biases that we see from sample selection, and also this like social desirability biases that we see in other samples that have tried to look at community attitudes. So I think it's a really useful way to look at these factors. Okay, so moving on to the data. Of course, we're using the results from the Marriage Law Postal Survey. So if you cast your minds back, you'll remember this was held in 2017 via postal service between September and November. And it was sent out to all eligible voting Australians saying, should the law be changed to allow same-sex couples to marry, with a yes or no response. The survey was actually voluntary to participate in this, but around 80% of all Australians elected to participate in the survey. And the results, which were released end of 2017, showed that just over 60% of Australians thought the law should be changed to allow same-sex couples to marry. There was, however, significant regional variation in response to the marriage equality survey. And this map here is showing the regional proportion of no votes out of the voting population across different electorates. And it's put into quartiles where basically the areas with stronger opposition are in the darker purple and lighter opposition are in the lighter colours. And if I can try and move this over now. I basically want to highlight that there is a huge amount of variation across regions. So it's not actually just as simple as a rural urban divide, which is what we saw more in the voice referendum. It is not as clear cut as that. And actually, the highest share of no votes in Australia was in the, I can't really show it, but in Western Sydney here. So actually, there's a huge source of variation coming from metropolitan and urban centres in Australia. And that's the kind of variation that we're proposing to exploit when we look at our different health outcomes. Okay, so that's what we do. We then link these responses to different data sets. So there's two different data sets we've used. One is the person level integrated data asset, PLIDA. This actually used to be called MADIP. They've just changed the name, which is why it's a bit confusing and hard for me to say. But I've done two papers with this. And then I've done one paper with the gay community periodic surveys, which I did with Curtis and Ben. But basically, I'll tell you a little bit about each of the surveys. But with the PLIDA data set, essentially what this is it's linkable whole of population, different administrative data sets, all linked together at the individual level. So you've got the censuses, tax records, social security records, MBS and PBS data. We've actually got it down to the item code level now, date of supply level, and you've got death records. So there's so much information in there. What I will say is, however, these censuses are not linkable as yet. You're not allowed to link them. So you can't follow people over time based on their demographics. You're only allowed to use one census linked data asset at a time. So specifically for these papers, to look at the healthcare use back in 2017, when just after the marriage equality survey, that was using the 2016 linked product. But then the one that I'm talking about today, looking at long-term health conditions, that's a 2021 product. And look, this PLIDA data asset is very, it's full on. So I'm very happy to talk in more detail about these data assets and what is available there. But it is really a great asset, but it is complicated and it takes some time to wrap your head around it. But the main thing that's really useful for my research is that from the censuses, you're able to identify people who are in same-sex relationships at the time of completing the census. They had to also be living together at that time as well. So you are missing single and non-partnered, as well as younger populations quite a lot. And of course, no information on gender identity as of yet. So from these two samples, though, we have pretty good sample size. So 80,000 people in same-sex relationships in the 2016 data asset and over 130,000 in the 2021 sample. So really, really good data. And sample size. We've also got information on their location, which is really important, of course, for this research, because I need to link to the marriage equality results. And information that I'm talking about today that I've used is the healthcare use. That's available from 2011 onwards. And specifically, I look at GP visits, mental health care services, sort of other primary healthcare use, like pathology services and things like that. And also whether individuals reported a core activity limitation at the time of the 2016 census. And I'll tell you a bit more about the 2021 data product later on when I talk about my current working paper. Okay, and then on to the gay community periodic surveys. As many of you will know, I'm sure, these are repeated cross-sectional surveys from GBM. And we also have a pretty decent sample size, so over 43,000 responses between 2015 and 2019. And from this information, we've got all the self-reported information. So we've got their location, which we had at the postcode level. And then we've got information on their use of STI, HIV testing, PrEP and PEP awareness and use in the past 12 months, I believe it was, HIV status, and among those living with HIV, whether they're on combination therapy and their use of HIV-related clinical care. So quite comprehensive information on that. So as I'll mention briefly, these two papers I've actually published already. So one is in JADES with Curtis and Ben, and that's looking at the sexual health outcomes, and the other's in social science and medicine, and that's looking at the healthcare use. So if you are interested in knowing a bit more, you can talk to me afterwards or look these up. But as I mentioned, I'm just kind of briefly touch upon the approach for these papers because I want to spend a bit more time on my current working paper later on. Okay, so really the approach for those two papers is that we're assigning no votes based on individuals' reported location of residence. We then do a bunch of different models where we're looking at different outcomes for people who are living in, say, an average stigma region, and then seeing how those outcomes change compared to people who are living in a region with more stigma, specifically a 10% increase in no votes. So the example I've given here is that I demean everything. So I look at, okay, what are the outcomes for people living in the average stigma region, which is 38% no votes? And then how does that change if we move to a region with more absolute 10% increase, 48% no votes? So that's how it works. It is different depending on the data set we're using. So in the PLIDA data asset, because I have information on people who are in sort of different sex relationships, they sort of serve as a control group. And that way I can look at disparities relative to that group. And the reason that's useful is it enables me to control for regional level fixed effects. So it controls for all other unobserved regional level characteristics that could also affect healthcare use. So things like accessibility to healthcare services, cost of healthcare, supply, those sides of things. Whereas in the GCPGS, or Community Periodic Surveys, this is only GBM. So I don't have like a control group, but instead I'm just looking at how outcomes change within GBM in high versus low stigma regions. So that's a bit different, but essentially we still also control for regional level characteristics like observable characteristics. So supply of healthcare, CFA, population density, things like that. Okay, and so here are the results. I'm just going to really talk through them. So from the PLIDA data analysis, we find that among those in same-sex relationships, a 10% increase in no votes is associated with a 5% increase in mental health scripts for females, 1% increase for males. Also find it's associated with a higher probability of reporting a core activity limitation. We also see that more stigma or greater share of no votes is associated with reduced primary healthcare use. So fewer GP visits and also fewer use of pathology services and anti-infectives among males specifically. And because we have such a large sample size there, we also do some heterogeneity analysis, and we find that these effects are slightly larger for people with lower years of education and generally larger for males, as you can see as well. And then in terms of the community survey results, we find a 10% increase in no votes is associated with reduced likelihood of having a STI or a HIV test in the past 12 months, and I think ever as well. And very strongly associated with the probability of you not being aware of biochemical prevention strategies like PrEP or PEP. We also found that there was a 6% increase in the probability of not being aware of your own HIV status. And among those living with HIV, you were less likely to be on combination therapy and you received fewer HIV-related clinical visits. So really altogether, taking these two results together from two different data sources, you can say that on average, higher share of no votes is associated with poorer mental health, poorer general health, but less primary care access among LGBTIQ Australians, and in particular important HIV preventative care. And the other thing I really like about having these two studies done separately is that when I did that first study, there was a bit of a pushback from other economists being like, yeah, but it could be that people are just accessing non-Medicare related services in higher stigma regions. So they're substituting away from those to potentially more inclusive care. But then now when you combine it with this survey level data, you see that that's not the case. So it's not substitution, it's just reduced use of primary healthcare. Okay, so now I'm going to focus a bit more on my current research, which is looking at structural stigma and sexual orientation disparities in long-term health conditions. And just to note as well that this is joint work together with co-authors Yuting Zhang and Zoe Aiken, who are both at UD Melb with me. Okay, so the data I use for this analysis comes from the 2021 linked PLIDA data asset. And the reason I'm using this is that for the first time in 2021, they asked a question, do you have a long-term health condition? So that is really why I'm using this. I've also got a larger sample, of course, do the same approach, link it to the share of no votes. But this is the question, and I don't know if any of you remember filling this in at the 2021 survey, but I remember filling in and being like, I've got to look at this. So the question was, have you been told by a doctor or nurse that you have any of these long-term health conditions? And they specifically said to include health conditions that have lasted or expected to last 6 months or more. So really getting at long-term chronic conditions. And if you selected yes to that question, you were then able to respond if you had any of these 11 conditions listed below. So arthritis, asthma, cancer, dementia, and so on, mental health conditions, and then sort of a catch-all term for any other long-term health condition if it wasn't listed below. And I'm not entirely sure why they decided to come up with this question in particular. If you look at other censuses around the world, they've used different questions to try and get at health and other self-rated health measures. The reason that I find it very interesting is that the question says, have you been told by a doctor or nurse that you have these conditions? So naturally, like what I've just showed you is that in these higher stigma regions, LGBTIQ Australians aren't accessing healthcare as much. So you have to be accessing healthcare to know that you have these conditions. So it's really important to keep that in mind when I do these analysis. And I think potentially we're going to be looking at an underestimate because of this, because of the way this question is asked. Hey, so here's some descriptive statistics from the linked data source. So I've got around 10 million people in different sex relationships and just over 130,000 in same-sex relationships. On average, those in same-sex relationships are around 7 years younger than those in different sex relationships. They're also more likely to have higher levels of educational attainment and higher household incomes. And that's quite consistent with what I saw in the 2016 sample. And then if we look at the health conditions, these are all unadjusted. We see that those in same-sex relationship, around 41% are reporting having a long-term health condition. And that's slightly higher than those in different sex relationships, despite being, on average 7 years younger. So really strong disparities we're seeing just looking at the unadjusted descriptives. And then the largest disparities are for mental health conditions. So 17% of those in same-sex relationships reporting have a long-term mental health condition, compared to 8% in those in different sex relationships. So very large gap here. And we also see some differences in terms of asthma, and then not too many other strong differences as we look at these other conditions. And then if we look at, these are just some regional level characteristics. This is what I've shown in previous research as well. We see on average those in same-sex relationships are more likely to live in lower stigma regions, so areas where there was less opposition to marriage equality. We also see they're more likely to live in areas that have slightly higher area level resources based on the CIFA measure at the regional level, also slightly more likely to reside in major cities. Okay, so onto the methods. Essentially, we just run a bunch of different logistic regression models looking at all these outcomes. We're doing disparities again, where we're looking at the odds of reporting a long-term health condition if you're in a same-sex relationship compared to someone in a different sex relationship who's living in the same area as you, specifically the same electorate. And then we're seeing how those disparities vary across different levels of stigma. And specifically, we break this into quartiles. And that's based on the distribution across electorates in Australia, which is from that map I showed you before. So we look at all of the long-term health conditions that were mentioned in the survey, all except for dementia, because we just had a really low sample size of positive respondents there. We control for electorate fixed effects. So these are all those unobserved regional level characteristics like access, supply of healthcare. And then in individual level controls, we just control for age, sex, educational attainment, and household income. We've got this same-sex, I don't know if I can see that there. Anyway, there's a same-sex relationship indicator variable there, and then we interact that with the quartile of stigma. So basically, the main coefficients of interest are 4 different coefficients, and they tell you what's the disparity in reporting long-term health condition relative to someone in a different sex relationship living in the same region as you. We do this overall, and then we stratify it separately by sex, age, education, socioeconomic status, and rurality. So I'll show you some of those results from that later on today as well. Okay, so here are the results just for looking at any long-term condition, and I'll show you the rest of the results sort of more graphically. But basically, we look at this top row here. This mouse is not working for me, but the top row here is the lowest stigma region. So these are the areas where there was the smallest opposition to marriage equality. And we can see that even in those regions, compared to those in different sex relationships, those in same-sex relationships are like 68% higher odds of reporting a long-term health condition. And then as we move up across different levels of stigma, we can see that there's almost like a dose response there, and it's increasing as we move into higher levels of stigma. And if we look at the area with the highest share of no votes in the country, we see that that jumps to 80% higher odds of reporting a long-term health condition. Okay, so there's lots of different outcomes, so it's very difficult to kind of show this all nicely. But this is essentially just showing for those different outcomes I've looked at, what's the odds ratios in likelihood of reporting those long-term health conditions relative to someone in a different sex relationship. So that top result there, any long-term health condition, that's just showing you the coefficients that I just showed you on the previous slide. And I think the most important takeaway that I get from this straight away is that when you look at all of these conditions, for every single one, you can see you've got a higher odds of reporting that condition across all levels of stigma. If you're in a same-sex relationship, you're more likely to be reporting a long-term health condition, even when we're controlling for these individual and regional level confounders. Then in terms of the effects by stigma. We know that that's our baseline model. What we did, we saw that sort of dose response with increasing trends and increasing odds of reporting long-term condition as stigma increases. And we see those similar trends as well for asthma, but this maybe a little bit for cardiovascular related conditions, but really the strongest effect, and it's so clear, is for mental health conditions. So in the lowest stigma region, you've got double the odds of reporting a long-term mental health condition, and then it jumps up to 2.5 in the areas with the highest stigma. So really we're seeing these sort of trends in increasing disparities as stigma increases, and it's very consistent with previous literature and what we would expect, I suppose, stigma-related process to be impacting the most. Okay, and so here's some heterogeneity analyses, and it's just focusing on those three main health conditions that we saw the strongest effects for. So long-term health condition in black, asthma in pink, and mental health condition in blue. But basically, again, we're just looking at those trends and seeing where we're seeing the strongest effects. And the first one here is showing by different age groups. And you can see here, these trends, in terms of the largest disparity with the highest level of stigma, it is largest for those who are under 40 years. You can still see it there for those aged 40 to 64 years, particularly for mental health conditions. But then when we get into people 65 years and above, it's a lot noisier. We don't see as much going on. And then we've also done it separately for those just by sex. And we can see that although there's some differences in the absolute disparities, if we're talking about the trends with the stigma, we can see that the jump tends to be larger for mental health conditions for males. So it's a bit hard not being able to show, but basically we're going from just over 2 and then closer to 2.7 for example, for mental health conditions for males. So really suggesting that the effects are larger for younger population and males. We've also done quite a lot of other heterogeneity analysis and robustness tests, which I won't show you today because there's just so many outcomes and so many different tests. But basically, we see that the results are generally similar if we look at socioeconomic status, education, and actually when we look at rurality, we see, if anything, the effects are more driven by those living in more metropolitan regions. So it's quite interesting there. If I try and okay, and then another important thing to note is this selection. So this is another important criticism of this sort of cross-sectional analysis, which is that we know that, and we actually showed this in the 2016 linked asset, those sexual minorities living in high stigma regions, they're more likely to migrate away from those regions compared to those who are in who aren't identifying as in a same-sex relationship or so on. And so this does suggest there's something going on. People are moving out of these regions. And generally, in all of the other sort of economics and social science literature, we know that there's a healthy mover effect. People who move tend to be healthier and able to move because they can. However, that is not what we see in this population. If anything, when I look at those moving to the lower stigma regions, they are actually in poorer mental health compared to those who didn't move. So potentially, and I'll just show you the results here. These are the overall results. And then this is when I restricted to people who didn't move in the last 5 years. And actually, if anything, it looks like the effect size is larger when I restrict to people who hadn't moved. So again, I think this tells us that we actually underestimating the effects of stigma, and potentially those who are sort of more affected are experiencing adverse health outcomes and then moving. And this is actually consistent with what other research in the US has shown. So it's interesting we're seeing similar patterns here in Australia, but really also suggesting that this lifetime exposure to structural stigma could be really important. And I think that's an important avenue for future research as well. Okay, so now just to summarize, basically from putting all of this research together, I think it's safe to say that structural stigma is associated with disparities in health and healthcare use among LGBTIQ Australians. We see that these effects are particularly pronounced for mental health conditions, but also asthma and CVD-related conditions potentially. So those conditions that we are sort of expecting to be affected by social stresses. And we see that the disparities tend to be larger for males and younger populations. And as I mentioned before, we know that this is really important because it looks like despite being in poorer health, on average, they're using less preventative and primary healthcare. So it has really important implications, not only for downstream development of acute and chronic conditions, but also HIV-related care and broader HIV prevention in Australia. Then I just wanted to note as well, it's consistent with previous research that they're at heightened risk of social stresses. We've also seen that these effects have been larger among male populations in the US as well, and also I think in Poland. So there is some consistency there with what's going on. As I mentioned earlier, I think that these effects are likely to underestimate the true effects of stigma. We've got that moving population that I mentioned before. We also saw the effects were larger for younger populations, but these are also the population that we're less likely to see in the PLIDA data asset, just due to the nature of its construction. So I think potentially there could be larger effects there. And of course, the number one I mentioned earlier, which is you need to have been accessing care to be diagnosed. And this could be also one of the reasons why I don't see potentially as large effect in the more rural areas when I look at disaggregating by stigma. And then in terms of implications in future work, I think one of the biggest things that I think everyone is kind of advocating for in this space is that we need ongoing data collection of sexual and gender diverse populations in Australia. It's really difficult to have these informed and targeted policies without that empirical evidence base. I think that I'm really hoping that this will be happening in the 2026 census. In December, they announced that they will include sexual and gender diversity in the census. However, they did say that last time. So we'll see how that goes. In terms of the PLIDA data asset as well, I think there's a lot of scope to look at broader work in terms of disparities, but also stigma-related disparities in terms of medication adherence, downstream use of hospitalisation and acute care services. That is, in theory, going to be linked into the PLIDA data asset in the next couple of years. So that is possible. And then other things such as lifetime exposure, temporal changes and policy changes will be really important to look at, and seeing what policies are actually effective at reducing these disparities. And then I think the number one thing I always say is there's obviously ongoing work to be done to try and reduce discriminations against sexual and gender diverse populations here in Australia. And already we could say we should be targeting interventions to areas where there was a higher share of no votes, potentially as well younger populations, male. So you've already got a few actionable things you can implement from this. Okay. And that's it from me. Really looking forward to hearing your feedback. So welcome any questions.
Thank you, Karinna, for the great talk. I think a lot of people here at Kirby are very interested in health disparities, particularly for LGBTQ+ populations. And I think also increasingly interested in health economics and that approach and what insights it can provide to us. So I thought it was really important for you to bring that talk in. We do have questions, time for questions, and online, if you online, please ask questions in the Q&A chat, and you can upvote the questions that you're more interested in getting answered, and then we'll answer those first. In the room, obviously, we can answer. You can ask questions on the mic. So I think we'll start off with Philip, and then I'll move on to the online questions.
Thanks, Kirby, and thanks, Karinna. It's really fascinating research, and I think it's interesting for Kirby in particular because of the many populations that we work with, not just sexuality and gender diverse populations, but other people who are impacted by stigma in other ways, other populations who may be suffering, similar sorts of effects from structural stigma in relation to their lives. I had a question in my head, but it might have changed a bit with one of the last things you said about people who move out of areas with higher stigma. So my question was going to be whether there's any evidence in your research or others about whether people who spend a long time or maybe grow up in areas with high levels of structural stigma, whether that has a long-term effect on their health. But you said that that you looked at people who move and that they had worse outcomes than people who don't move. I wasn't sure whether you meant people in the same area that they were from who don't move, or all people who don't move.
Okay, so yes, I think that this is like something I really want to work on in the future, and it is getting more possible to look at these effects over the live course, but we are somewhat limited with the data that we currently have in PLIDA. I think in the next 10, 15 years, we'll be able to do this live course exposure to stigma properly. So to your question, I can't go back too far and look at their location. Only for people who were partnered in 2021 was I able to backtrack their population for the last 5 years. And even among that group, it's like only a subsample, for example. But so what I've done is I looked at the movers and their health conditions compared to people who also identify as being in a same-sex relationship, and then compare that, their outcomes compared to people who were already living in the lower stigma region, as well as compared to people who were in the higher stigma region. And basically, if anything, I see that they definitely have worse health than the people in the low stigma region. So you can imagine that is bringing my average effect down, like it's biasing my effect upwards, because it looks like people in the lower stigma region are in poorer health, but it's not actually based on their current levels of stigma. It's based on their past levels of stigma from those movers. I do not know if I explained that properly.
No, that makes a lot of sense, and I guess I'll get away from the microphone. But I guess my other question was about whether there's variations within people within each of those regions based on the level of structural stigma, because different levels of income and things would have an independent effect, perhaps.
Yeah. So within people in same-sex relationship in the same region.
Yeah.
Affects. Yeah.
I think, not to jump in too much on the analysis, but I think all of your analysis also try to control damage for income, as well as the level of health services available in a region.
Yeah.
So it is really trying to disentangle this measure of structural stigma away from some of the other usual confounders that we would think are associated with healthcare access.
Yeah.
But
and then it's interesting as well, when I did some of those heterogeneity analysis, for example, by income and CFA, I didn't see actually too much going on, especially even when I did it by education. So it's not necessarily that, like that's what I was expecting, potentially, the intersectionality of disadvantage. There's this whole literature in this space. So potentially we would expect to see larger effects among those with lower human capital due to other factors. But yeah, I haven't seen too much, which is interesting. But bearing in mind, people have to be accessing healthcare, and we know that there's a socioeconomic gradient in accessing healthcare as well. So it is complicated, and that's why I really want to look at other self-reported measures of health, not this long-term condition measure only. But yeah, good thought.
We're going to have a couple of questions online, and then we'll move to ones in the room. So first up, I'm just going to read it word for word from Carla Chulor from the Center of Social Research and Health, who does a lot of work on stigma. She says, thanks, really important work, very clearly presented. Any data on the costs of disparities? Or can you see further work that estimates costs of these disparities? I know some work on costs of mental health stigma and racism costs.
Yeah, absolutely. I don't really have capacity to do it at the moment, but I really want to. And it's absolutely something you could do with PLIDA as it is. We've got information on, well, specifically when we're talking about healthcare costs, we've got information on government expenditure, out-of-pocket expenditure towards different services in PLIDA. We haven't got information on the acute care costs, which is, I think, where the really large effects are going to be in these hospitalization costs. We haven't got that yet, but it will be coming. And I think when that comes, I think having this kind of holistic healthcare cost effects of stigma research will be really important.
And I think just to kind of piggyback on something that you had said during your presentation about why working with the gay community periodic surveys, that added level of self-reported use of potentially not Medicare subsidized or not in the MBS system healthcare services was really useful. So if in the future, you might want to come back and look at some of our other behavioral data or survey data. So just, spruiking some other ideas. All right, so another question online from Bridget Hare. Thank you for a great presentation, Karinna. I work with the ABS on LGBTIQ+ inclusion and plans for inclusion in the census so far. It looks unlikely to be derailed, and the questions have been negotiated with our community. So I think that's more of a comment.
Oh, that's a relief. Yeah.
But yes, I think a lot of us are really expecting the question in the census on gender and sexuality. So hopefully we can see a little bit more of that in the next census. I think, Deborah, you had a question?
It's really good news.
Yeah, so I guess I was really interested in it. It was a great presentation. Thank you very much. And it was really interesting. But so I guess when I was looking at it, I thought the correlation with mental health makes, I guess, perfect sense, because you can imagine that living in a high stigma area would be somewhat trying on your mental health. So I've got two, I guess, related questions. The first one is, I personally didn't understand the strong correlation with asthma, but then you said something in your talk that made me think that maybe there was some understanding of how that was related to stigma. I don't know, but so that was super interesting. But then I guess what was also interesting was the overall effect. And have you considered running your analyses but excluding mental health conditions, simply because I guess that makes a lot of sense and may or may not be related to worse access to healthcare. But that aside, the fact that it existed for asthma, super interesting, and heart conditions. And I just was wondering if you could run everything you did again, but leave out mental health conditions, and whether you thought about that or tried that on, and what the link was to asthma.
I hadn't thought of that. That's fantastic. I will definitely do that. The asthma thing was really surprising to me too. And then I ended up talking to, everyone I knew about it, and especially a lot of GPs and psychologists, friends. And they said that the link between asthma and mental health conditions is actually very, very strong. And then I went out and did a lot of reading on this. I didn't find too much causal evidence. There's a lot of mental health precipitating asthma and vice versa type research, but basically they were saying that a lot of the symptoms are very, very similar. For example, hyperventilating, experiencing a stressful event can actually bring on asthma, and if you're already predisposed to having that, it could trigger it in that sense. So, but yeah, that was a really interesting result.
So I guess in that sense, maybe you want to run it without mental health or asthma. I mean,
yeah,
I don't know. And then another, I'm modeling like whether there is, a link that is separate from the mental health.
Well, there's definitely,
so if mental health in and of itself leads to worse outcomes, as does low SES and all that sort of things. I wonder if there's a way of disentangling that aspect to really hone in on the worst aspect, access to health. And it's not to play down the mental health. It's just that's something that we might expect, whereas the other stuff is maybe less.
I agree. Yeah. And the other interesting thing is that it's, like I was mentioning, I was trying to get at a bit earlier, but it's like mutually reinforcing. And given I've shown in the other research, you're less likely to access preventative care. That's also a mechanism through which you could affect all types of different health outcomes. And even though it wasn't maybe super clear in those slides, but basically for most of the outcomes, except for really diabetes, you do see that trend.
It was really clear and super interesting.
So
I was just thinking,
I think there's other, I agree. Really there's other mechanisms.
Get into that even more. Yeah, thank you.
Thanks so much.
Hi, thank you for your talk. It was fascinating. I was wondering if you've thought about drawing the causal pathways between stigma and the outcomes that you are looking at, or if you've read any literature that supports any causal relationship between stigma and the series of health outcomes that you've explored, and that can actually support future analysis.
That's the hardest part because it's very hard. I have actually tried drawing it out, and then I'm just I end up ditching the diagram again. Anyway, but I will talk about in terms of causal evidence. This is difficult. I'm using people in different sex relationships as a sort of control. So you can think of it as a pseudo difference in difference design in that sense. I'm not saying it's causal, but it is very consistent with other research, which I think is more causal. If I think about broader research on structural discrimination and health outcomes, there's some really great papers that come to mind. So some, for example, was September 11 being an exogenous shock towards discrimination against Muslim community. And we've seen that had a really dramatic impact on mental health among people in the UK based on their longitudinal survey there. We've seen similar things with Brexit. So looking at impact of Brexit on non-native immigrants as well. And that's really the main way people try and get at causality in this space. It is really tricky.
And I just wanted to add on that a little bit is that, we're looking at this whole population level data, and it's routinely kind of collected data. We weren't necessarily, people weren't running the Postal survey or the no vote to measure structural stigma, right? Your analysis was looking at thinking of kind of opportunistically being able to connect those two things and operationalize structural stigma in that way. So it's really difficult without having a very kind of clear intention to try to draw out the causal pathways. But I think regardless of that, I think your analysis did show a very strong link between structural stigma as operationalized by the Postal survey with all these health outcomes. I think on that, please, more questions, but I had a question of my own. I think some people in the room that might be thinking, oh, you did this analysis with the marriage equality survey that a lot of people did, but you kind of teased it a little bit, and I wanted to know a little bit more about the recent voice vote, how, you know, these big census level, population level surveys, again, not necessarily for research design purposes, how do you think about these and how do you approach these big surveys when it comes to trying to link it to MBS or PBS or other things? What are you looking for?
Well, okay, so it's quite interesting, the voice thing. I might sneaky show you some results. But basically, I think it's best to use the data set that works best for the research question you're asking. Funnily enough, the very first thing I tried to do with the voice referendum results was look at long-term health conditions. It completely didn't work. And the reason that is because of this needing to have accessed a doctor or a nurse to have been told you have a condition. And so actually for that specific question, can I show it? I kind of want to show you. I'm just really quickly going to show you, but just look at this. Oh, no, you can't see it. But so basically I didn't end up using the Plata data asset. I ended up using Hilda. This is very preliminary, by the way, but it's very exciting, I guess, because it's very policy relevant. So just look at the top right panel. This is very confusing because we haven't done this, but basically that's for mental health, Indigenous in blue, non-Indigenous in black. And that's quartiles, opposition to voice. And basically you can see that in areas where there's, like in the lowest opposition, prevalence of poor mental health is very similar. But then as you increase opposition, we see the prevalence doesn't actually change that much among non-Indigenous Australians. When we look in the highest stigma regions, we see that that's actually jumped up quite a lot for Indigenous peoples. So this is all this like very consistent with this other body of research I'm working on. But just to note, it's like that Plata data asset was not appropriate for this research question because even just as an example, I think it's very well known that on average, Indigenous peoples living in more rural, remote parts of the country have poorer mental health. I think that's very well known. If you look at that long-term health condition question, you don't see that relationship. It's because they're not accessing care. So they don't know they have a long-term health condition. So that question isn't necessarily always appropriate. Yeah.
All right. I think
Anyway.
at time, again, can you please join me in thanking Karinna for a great talk?
Thank you.